Okay, let's start. Let's get started. And welcome to everyone to our Thursday morning's HIV Center Grand Rounds. Great to have you here. And we have a really wonderful speaker today that I'm very pleased to be introducing in a minute. Let me first tell you about upcoming events from the HIV Center. And we have two panel workshop presentations coming up and in October. And that's in 2 weeks, on October 17th, we have a panel that will be moderated by Dr. Robert Klitzman, or Bob Klitzman, who, and this is being sponsored and put on by the Development Corps of the HIV Center. And this panel and workshop is entitled Implications of the Dobbs Decision for Women Affected by HIV, Clinical Research and Ethical Challenges. So that should be very interesting and stimulating. We have some of our own people engaged in this and some outside speakers. I'll just mention, including Dr. Lisa Rohingdale from University of North Carolina, Dr. Mauda Monga of the University of Mississippi Medical Center, and Dr. Sarita Sonalkara of University of Pennsylvania. So this will be a very important, very interesting event. And then we have another workshop that will include panelists. I'm not going to mention names at the end of October, on October 29th. And this workshop is being sponsored by the Clinical Translation Corps of the HIV Center, and along with our NECA ATC, the Northeast Caribbean AIDS Education and Training Center. It's about the HIV workforce, and we'll be sending out details about that as that is still coming together. So, put those dates in your calendar, October 17th and October 29th. Okay, so without further ado, I'm going to introduce today's speaker, who asked me to keep it short. I'll try and keep it short, but I want to emphasize the diversity of her background, because I think it's important to what she's talking with us about today. So Dr. Michelle Cespedes is a tenured professor of medicine in the Division of Infectious Disease at the Icahn School of Medicine at Mount Sinai. And she wears many leadership hats, including co-director of the ID Division's Clinical and Translation Research Center at Mount Sinai, the clinical research site leader of their comprehensive health program, and the director of HIV service for the Mount Sinai Hospital, as well as associate program director for internal medicine residency program at Mount Sinai. So you can see that Dr. Cespedes is engaged in research, clinical work, and also mentoring. Her educational background is diverse too, having gotten an undergraduate degree in biophysics from Johns Hopkins University, medical degree from Mount Sinai School of Medicine, and then did her residency here uptown in at the Cornell side, but at New York Presbyterian Hospital, Cornell. And then doing an infectious disease fellowship and master's in clinical investigation at NYU. So, just her research interests are diverse as her background is and as her leadership roles are. HIV prevention in high-risk populations, complications and comorbidities of HIV, and HIV-related women's health issues, as well as basic science interest in genetic factors that predispose HIV patients to HPV disease. I think she's ideal. She's led large AIDS clinical trial groups, evaluating efficacy and immunogenicity of the preventive HPV vaccine in both men and women. So given the breadth of her expertise, we're really pleased and fortunate that Dr. Cespedes is here today to speak with us about the HIV highlights in 2024. I will turn it over to you, Michelle. Thank you.
Thank you so much. Thank you for the invitation, and I jumped at the chance to really kind of review some of the things that I think, that made my heart beat faster over the past year. If I couldn't pronounce either a new antibody or anything of the sort, I really wanted to focus this talk on things that I think will make a change or a difference, either in our understanding or actually what we plan to do for our patients and people that we actually want to prevent from having HIV in the first place. All right, so let's get started. Here are my disclosures. But really, like I said, I really wanted to review some of the updates from randomized clinical trials that have really been presented at the meetings in the past year or so, some of one or two from the end of 2023, and really talk about some of the new directions that we're going into with, long acting, all the rage is long acting, but what are some of the caveats or things that we have to keep into consideration, and also what things might be on the horizons as well. Another interest of mine as well, I sit on the Department of Health, the AIDS Institute guidelines. Really, of all the data that we hear, some of it's basic science, some of it is, in resource limited settings. What are the things that we might hear about that might actually change what is recommended for the patients that we take care of in terms of guidelines? And, the reason I always bring up guidelines are guidelines actually oftentimes sway what insurance companies will pay for. So it's one thing to think that something's great, but if it's not on the guidelines, sometimes it's not that easy to actually make it become a reality in the larger scale. So for the first section, I wanted to really kind of just review and go over some of the highlights with long-acting injectables. I was going over slides last night, and I was like, I don't want to take it for granted that kind of everyone, cabotegravir has been the word of the day for probably the last 5 years or so, but really going over just kind of some of the key points. So for those who may or may not be aware, actually, when I was putting my slides together, I actually didn't realize that this first study that really kind of put cabotegravir for treatment on the map is from 2020 already. All right, so we're hitting the 5-year mark. So cabotegravir is in the integrase inhibitor family, right? So it prevents the HIV-coded DNA from getting into our DNA and kind of going through the motions. An integrase inhibitor, there is a tablet form, but the tablet was really just used to kind of get your body up to speed and maybe make sure that you didn't have an allergic reaction. So oftentimes we don't use the tablet anymore, but just go straight to the injectable, which is really when it became a game changer. So it's a long-acting injectable. The original studies for treatment actually pair cabotegravir with another medicine that we've had around for a long time, rilpivirine, but rilpivirine also has an intramuscular long-acting version. So the original studies looking at cabotegravir, the Atlas 1 and Atlas 2 trials, really paired the two together as injectables for people who were already on a stable HIV regimen, right? Already undetectable for at least 6 months, had no resistance to these two medicines in these classes. So based on those studies, one of the biggest ones right there on the right, uh, cabotegravir plus rilpivirine together as Cabenuva were FDA approved as a switch regimen for people who were already undetectable and doing well on the stable regimen. Since it's been FDA approved, some of the unexpected things that we've learned are kind of in hindsight, with that there were really issues with how this was going to be done in real life in the clinics, right? Atlas 2 actually showed it doesn't have to be every month. It could be every 2 months. Who's going to do it? Can it just be the nurse? Who's going to pay for it? Is this an insurance? Is this, a brown bag? You get the medicine somewhere else, but someone else gives it to you. Because it's an intramuscular injection in one of the muscles of the buttocks, it's not something that you can just get kind of like a pharmacist gives you your flu shot. But really between cost, logistics in clinic, and things that kind of weren't really combed through before it became FDA approved, the initial uptake with who was getting it, which clinics were approving it, between insurance approvals and coverage, initially for the first 2 years, I'd say 2+ years, lower than expected uptake for cabotegravir as well. In terms of the prevention space, for prevention, we actually don't have to combine it with rilpivirine, but these large HIV prevention trial network trials, 083 and 084, these were PrEP clinical trials actually comparing just cabotegravir all by itself, given once every 2 months, to the standard of care, which was once daily Truvada. These two trials, one for essentially men who have sex with men and transgender women, and 084 was for women of childbearing age, I should say, in sub-Saharan Africa. Really, those two clinical trials were actually stopped earlier than expected, because people who were randomized to receive the injectable cabotegravir actually had such few rates of HIV, was found to be superior than daily Truvada for preventing HIV acquisition. Right? So the trials went on, but they actually had to unblind everyone and do what's called an open label extension, had to offer everyone injectable cabotegravir for PrEP, just in terms of the ethics of it all as well. Since cabotegravir for PrEP has been FDA approved and in use, what they saw actually from some of the clinical trials is this thing that you may have heard of called Levi syndrome. Levi stands for long-acting early viral inhibition. So what they were seeing is that people who were even getting their cabotegravir on time, and the few people who they found a couple of cases of people who actually acquired HIV, but their regular routine HIV test didn't take just kind of a couple of weeks to pick up the HIV, but maybe a couple of months, even while they were still getting the cabotegravir. So this Levi syndrome is really a syndrome of delayed diagnosis of true HIV infection in people who were receiving cabotegravir for PrEP. Even though it was rare, but the recommendations actually changed. Instead of using our rapid fourth generation HIV testing, we should probably do HIV viral load testing to kind of pick up true HIV earlier for these folks. Now let's go into some of the updates over the past couple of years. They're saying with the advent of this new drug, injectable, people, really well tolerated, people have such high satisfaction. Wouldn't it be great if we actually could use it not just in people who are already doing well and agreed to be in clinical trials, and were already undetectable. But what about for people who really have had trouble taking tablets, either due to competing priorities, mental health issues, active drug use, intolerability of medications? Right now, the CAB plus rilpivirine is only approved for people already undetectable. But what about using it in real life situations for people who might not have been undetectable or have significant barriers to taking medicines, oral medicines, including mental health issues? So the smaller study in Australia only looked at about 60 people, but really looked at some of the things that I see in clinic all the time, right? Social isolation, almost a third with mental health disorders, either poverty essentially or food insecurity. And what they found is that even people with these competing priorities and significant barriers, nearly all of them were able to receive the injections at the right time. And what they did see was that everyone was able to become undetectable. There were no virologic failures and no serious adverse events. Right? And the issue is, especially because these two medicines have slightly different half-lives, they both can be given as injectables, but one could stay around in the body, that rilpivirine in particular, a little bit longer. So if you don't come on time or if you have missed injections, essentially after about 2 months or so, when the cabotegravir runs out, you'd kind of only be on rilpivirine alone, which is exactly what you do not want for someone with HIV, right? If you actually truly have HIV, you want at least two medicines that work in two different ways. So you really want to make sure there are no missed doses. The bigger study that we've all been hearing more about is really one by Dr. Monica Gandhi, another colleague out in San Francisco. Her clinic is called the Ward 86 Clinic. And similarly, she was like, actually, look, we have similar populations. I was talking to her just not too long ago. We were talking about, heroin epidemics and crystal meth epidemics. She's like, I don't know which is worse, but she insists that crystal meth is much worse. But really, barriers to care and compliance with taking daily tablets is a huge issue. And so many patients who have detectable virus who would benefit from these long actings as well. So similarly, the median age for the people in this study was just about 46, predominantly cisgendered men, but 2/3 of them were actually non-white. And a very large proportion were homeless or unstable housing. And again, similarly, a third with active substance use. Interestingly enough, out of these 133, almost half of them actually had detectable viral loads when they were initiated on the injectable regimen. And again, nearly 100% of those who had a detectable viral load, even though not FDA approved that way, were actually undetectable in just about a month. And she gave some updates earlier this year. They've had more patients actually now with detectable viral loads who have been started on treatment with cabotegravir, rilpivirine. And even at 6 months, we got nearly 100% of them undetectable at a month, but at about 6 months, more than 85% were still undetectable. So really fascinating and completely appropriate for the patient populations that we see in real life. Similarly, the AIDS Clinical Trials Group, ACTG, conducted a study really comparing CAB plus rilpivirine compared to randomizing people to continuing on their oral HIV regimen, again, in people with challenges to adherence. So this study actually was started initially before rilpivirine was every 2 months. So as you can see here, they were actually given, after someone got undetectable, they actually treated them, gave them tablets, also incentives, some cash to get them undetectable over 6 months, and then randomized them to either continue on the oral antiretrovirals or be given the rilpivirine once a month. So this study actually was designed before it can be given every 2 months, and then when people actually also had to be undetectable. So it might not necessarily be real world applicable today in this day and age, but still very valuable information, all right? So what they wanted to see is how well people did when we took away the money and the oral tabs or randomized them to continue on the tabs or the monthly cabotegravir. The thing I like most about this study is that it really looked like the populations that we see here in New York City in terms of the age of who was included. About 1 in 5 were young adults under the age of 30, about half between 30 and 50, and a full quarter over the age of 51. Here in the US, about a quarter, 27% of all those with HIV are female, much higher in resource limited settings outside of the US, but oftentimes studies don't actually meet that similar population. This study did, purposely enrolling a third women, included transgender, and more than approximately two-thirds were actually Black African American, and about 1 in 7 identified as Hispanic or Latino. In terms of history of intravenous drug use, another two-thirds either were currently or past IVD users. And basically the long and short of it was earlier this year, they too had to stop this study early because what they found is that there was statistically significant difference. People who were randomized to continue treatment on the long-acting cabotegravir plus rilpivirine did much better, were a third less likely to actually have virologic failure at the 6-month mark compared to the people who were randomized to continue on the standard of care, which was to continue on the oral antiretroviral treatment, even after those economic incentives went away. There's always a concern when I see a study that does economic incentives. Is that a real world, for a clinical trial, or you got funding to do that? But in the real world, would I be able to give patients either at NYU or Bellevue or Sinai or just here in New York City at Columbia, would it be reasonable or rational to give them $25, $50, $75 every time they came in? So really seeing what the outcomes were even after the incentives went away was actually really powerful for me. So based on this data that was presented earlier in the year, there's actually been some talk around next steps or next best moves. And really in terms of when supported by intensive follow-up and case management services, the idea being that if you can get people who are already difficult to stay or maintain on treatment with orals, having case management services and making sure that they get back to clinic on time or called and reminded about their visits and all the support possible if they're unable to take oral antiretrovirals or really, really high risk of getting into trouble, low CD4 counts, possibility of getting hospitalized or having additional OIs. Starting with cabotegravir, rilpivirine, even without an oral lead-in and even without being undetectable beforehand, really may be a consideration and may be of benefit as these projects have demonstrated. Next, I wanted to talk about what's new on the horizon and landscape for prevention. So I think for all these years, we think of HIV as treatment, preventing opportunistic infections, but especially for our populations and with just some of the other competing priorities and other social determinants of health, keeping people who are HIV negative that way, despite other issues, is also a big part of what we do. So remember, I spoke briefly at the beginning about the HIV Prevention Trials Network, HPTN 083 study. So that study showed, in both the 084 for women, showed that cabotegravir alone, given once every 2 months, was superior to Truvada, daily Truvada for preventing HIV. But because of that Levi syndrome, right, that late diagnosis of HIV, because of probably the cabotegravir and the long half-life, and maybe masking some early, especially HIV antibody testing. In 2021, the end of 2021, the CDC actually kind of moved guidelines and really started to recommend HIV viral load testing in addition to not just antibody screening for HIV, to really make sure we would pick up all of those possible quiet late detection of HIV to prevent Levi syndrome, even though it was a rare thing. So this study actually took a look at the participants in that HBTN 083 study. So remember, because they had to stop that study early because it was found to be superior, people were still being followed even when they continued to be on the long-acting cabotegravir that everyone had to be offered. So this actually looked at how many new cases of HIV were we picking up now that we were doing more viral loads instead of just antibody testing alone. And in terms of the delay in diagnosis, you can see here for participants who are on long-acting cabotegravir, for the people who did acquire HIV, you can see that for the delay in diagnosis was almost 3 times as long as those people who did develop HIV on Truvada alone. But this study actually wanted to investigate, of all those new viral load testings that we did, how many times did we actually pick up new HIV early, or at all, I should say, and how cost effective and effective it was. Really kind of pick up the positive predictive value and the false positive rate. So as you can see here, out of nearly 27,000 viral load testings, we got about 22 were false positive. And what they found is that of those false positives, for about 1/3 of those patients, what it actually did is prevent them from getting their next cabotegravir injectable dose while we're figuring out if they actually truly do have HIV. But again, as you know, in real life, when someone's off their PrEP, you know, the other concern is, you know, are they more likely to actually acquire HIV in those windows when they're not actually being covered? A single isolated positive viral load test was uncommon, but actually when it actually did happen, frequently it was a false positive test. And of course, those who actually did get viral load tests that were positive, they were more likely for it to be a true new infection if they were out of window or kind of missed their cabotegravir, a few cabotegravir doses. So if they had not received the long-acting cabotegravir in the past 6 months, then you were more likely to be able to trust the viral load test, right? So essentially, if you get a positive, what they're saying is maybe do another repeat HIV viral load, kind of have 2 tests to make sure the first wasn't a false positive. Next, I want to transition into lenacapavir. And for those of you who might have been aware, even for the lay public in the news, a lot of excitement has been going on about lenacapavir, especially since this summer. So for just a brief review, lenacapavir is a new HIV drug that it's in a class all of its own. So it's a new class. It is a capsid inhibitor. I'm not sure if you can, I think you can see my arrow, but the capsid is actually the green covering here on the inside of the virus. The way I teach my residents, the envelope is on the outside. Think of the capsid as the skull, and the HIV RNA and some of the preformed enzymes are the brains of the operation inside that skull. The capsid is important for HIV replication because it has to disassemble to let the HIV RNA out. It actually helps it get transported into the nucleus when the DNA, before the DNA integrates into the existing human DNA. And it's important for the maturation after budding to actually close up properly and to get back into that fully formed property. So lenacapavir binds subunits of the capsid. It disrupts the life cycle at 3 distinct points. And what's fascinating about this, as opposed to cabotegravir, which is currently dosed once every 2 months intramuscularly, lenacapavir as a smaller molecule can actually be given subcutaneously, and not once every 2 months, but twice a year, once every 6 months. End of last year, lenacapavir, anytime we have a new class that works in a new, different way, we actually always offer that, or the original clinical trials are for people who have no other options to get a fully active HIV regimen. So the original Capella trials actually took a look for people who have a lot of drug resistance, very highly resistant virus, highly treatment experienced, using lenacapavir, even just adding it to your old regimen and then making the best regimen you can. Really found people who had no options, not necessarily becoming undetectable in just a week or two, but having such a significant drop in their virus that it was proven to be fully active even with resistant virus. And over the past few years, what we've seen that people who even had no fully active agent, even the addition of lenacapavir with something even moderately, with some moderate activity, what we've seen even after 2 years, they're able to stay undetectable with their optimized background regimen with the addition of lenacapavir. So that's for people who have highly resistant virus. You know, the other things with lenacapavir, there are some drug-drug interactions, but it doesn't need to be dose adjusted if somebody has kidney disease or near dialysis. And we're actually looking at it. It was always in studies for PrEP and treatment naive people as well. So I just wanted to overview the clinical trials looking at lenacapavir for PrEP. The one that we made the biggest noise earlier this summer that we did get information on was the Purpose 1 study. Purpose 1 was only enrolled cisgender women of childbearing age, young adolescent teens to under 40 in sub-Saharan Africa, South Africa, and Uganda, and really compared them to both Truvada and also Descovy. Originally, this study was designed to compare Truvada Descovy, but then lenacapavir was built into the design to actually compare. Purpose 2 is a similar study, large, but looking at lenacapavir for PrEP given once every 6 months, only comparing it to Truvada, but in cisgender men, men who have sex with men, but also people who are gender nonconforming and purposely included transgender men and transgender women. These other smaller studies are actually still ongoing and will give us more information over time. But Purpose 1 and Purpose 2, large enough, international, and with the plan to make sure that they would give enough information for it to be registered with the FDA for information. So purpose one, again, we said lenacapavir compared with both Truvada and Descovy. I'm sorry, I'm not supposed to be using brand names. All placebo-controlled, and comparing new cases of HIV and all of the things. So in July, right before the conference, the International AIDS Conference not in Berlin, in Munich this summer, we got the information just about a week or two before before the before the conference. We actually heard the big groundbreaking news that the study had to be stopped earlier because it was found to be 100% effective, meaning zero new HIV infections occurred in the women who were randomized to receive true lenacapavir compared to those who are randomized to receive either emtricitabine, TAF versus FTDF. What's interesting, if you look at this chart, while there were standing ovations and claps all around, comparing what surprised me was that there didn't seem to be that big of a drop for those taking the oral PrEP options compared to background HIV incidence. And when I really looked into it and read the paper a little bit more, really what the long and short of it is that when they looked at the cases of HIV acquired and those who were randomized to these arms, when they did blood levels, they found that there were low blood levels, and really this is really probably all attributed to poor adherence. So just about 2 weeks ago, so actually at the conference, besides the standing ovations in July, a lot of leaders around the world and WHO and officials were really saying, what's next? Will this be available for everyone? Are you going to stop the other study that was looking at comparing lenacapavir versus Truvada in men who have sex with men and gender nonconforming populations? And Gilead actually said, no, different populations, maybe different risk. We're actually going to continue that study. And just about 2 weeks ago, we got the press release, and I'm a PI on the study at the clinic downtown, to hold our horses. The data had just come in that even in this population, while it wasn't 100%, they did find two participants who were randomized to receive true lenacapavir became HIV infected, but we haven't had all the data yet to see whether or not they might have missed doses, or if they might have actually had HIV at the time of enrollment. So we're still waiting on more details. But the long and short of it is that we've had to pause this study, not pause, but I should say we are actually unblinding everyone and going to be offering people who might have been randomized to tablets, true lenacapavir, to continue in this study, because this too was found to be superior than taking tablets alone for HIV prevention. And literally, while I was proofreading my slides last night, checking my email, stalling, got a little snack, I opened my email and saw, because I'm a PI, saw that there was a new press release that came out about 5 p.m. last night, that based on some of the response and with at not just the international conference, but around the world, Gilead has actually agreed to, actually have a rollout, and actually agreed to kind of hasten the generic manufacturers in resource limited settings to actually increase lenacapavir for prevention in resource limited countries, and especially so many of those countries where many of the prevention studies actually occur. So they're actually going to license these in 120 lower middle income countries, and which wouldn't include us, but 90 to 95% of all HIV is in these countries. So this is just really fascinating, and hopefully I'm looking looking forward to hear more about this as well. Another thing that I thought was interesting, it came out about the end of last year, but I haven't heard a lot of people talk about it, but I did come across this and I thought this was interesting. Really talking about any updates on what's called on-demand PrEP. So the original PrEP studies that came out 12 years ago now, wow, time is passing, really compared daily Truvada to standard of care for preventing HIV. And then over time, from those original studies, what was determined was that even if people were assigned to take Truvada every day, if they at least took 4 tablets a week, that they were able to get really effective HIV prevention or concentrations to prevent HIV. Over time, especially data from France, from the IPERGAY study, really looking at what's called on-demand PrEP. You may have heard of it as 211, taking 2 tablets of Truvada anywhere from 24 hours to 2 hours before a high-risk sexual encounter, and then 24 hours after 1 tablet, and then 48 hours after the encounter, another tablet, hence the 211, 2 tablets, 1 tablet, 1 tablet, which is showing really high efficacy and actually is in some of the guidelines, the European guidelines. It's mentioned in the US guidelines and some of the DHHS guidelines, but not actually a true recommendation. But I thought this was interesting. This was actually looking at a study where just under 700 men who have sex with men from resource-limited settings with high HIV prevalence, conducted just before COVID and maybe a year or so after. Participants would actually choose between taking PrEP, Truvada for PrEP every day, or on demand. On demand is here is referred to as event-driven PrEP. And they could switch, they could change their mind. But of course, I don't think that's such a surprise. About 70% of people chose to be on demand or event driven PrEP versus only about 1 in 4 chose to be on PrEP every day. What I thought was interesting was the HIV incidence was about 4 times as high for those who chose to be on on-demand PrEP. And really, it was really all about adherence. Adequate adherence was lower for participants who chose to be on on-demand PrEP versus those who chose to be on daily PrEP. So adherence was less than half for on-demand PrEP versus about 75% for those who chose to be on taking the PrEP every day. And again, similarly, just like I tell my patients with HIV, just as I tell my patients who are on PrEP, PrEP or treatment does not work in the medicine cabinet, right? If I give you the prescription, it doesn't work unless you take it. Similar to our patients with high blood pressure, similar to our patients with diabetes. It's all about getting the medicine where it needs to be and in your bloodstream, and really just shows that for the people who did acquire HIV, they had undetectable levels of PrEP in their bloodstream for those who did become HIV positive. I want to spend a few minutes talking about something that's important to me. You know, for years, I actually ran the HIV and pregnancy program at Bellevue. But really, I think one of the things that we as providers don't necessarily do a great job at is really speaking to our patients of childbearing potential, what their fertility desires are. If you have a kid, do you want another child? Are you aware that even though you have HIV, that you can actually prevent passing on HIV to your child? What are you using for birth control? So one of the things with my presentations I always like to remind people is to really have conversations about not just sexual risk factors or STI risk, but also fertility desires. I've encountered a lot of women who actually didn't know that they could have children and that their child would not be likely not be infected if they take their medicines. So over the years, what we've learned about prevention of mother-to-child transmission, we've had more data with more medications. There's safety in pregnancy. A lot of the concerns are you usually need at least data on 200 pregnancies and the outcomes in terms of birth weight, abortions, birth defects, before something can be added to the guidelines or have enough data um, to be included. So we're getting more information over time with more regimens, whether or not people of childbearing potential is the correct term, need to change their regimen. What if I get pregnant on one regimen and there's not enough data? We're getting more information about what might be best and options as well. Interestingly, I didn't actually know this until I had to review for the slide presentation a few months ago. For years, what we would do is actually give the newborns HIV medicines for at least 6 weeks or so postpartum to make sure that even though the original viral load testings were undetectable, we wanted to make sure that they didn't acquire it at the time of delivery. So we would give them for 6 to 8 weeks. Now the data is if really the mom is undetectable, full-term healthy baby, and the mom did not become HIV infected during the pregnancy, we can actually shorten the amount of time the newborn is exposed to that prophylaxis down to 2 weeks. And we've been having more input on guidelines and recommendations on the concept of breastfeeding. I think I took it for granted. I didn't realize this until working with the HIV Medicine Association. I think as New York might be more progressive, but there were places here in the States that a new mom could actually be penalized or threatened with CPS or having her child taken away if she decided to breastfeed with HIV, even if she was undetectable. So making sure that people are being honest with their providers and that information is updated even on the guidelines. The guidelines regarding breastfeeding hadn't been updated for nearly 2 decades. So now that we have better regimens and more information, making sure that states and prosecutors and even child protective agencies are aware of that as well. In terms of preferred regimens during pregnancy, the lists are here, but really making sure, I think as we evolve with what's safe, as we have more information, while integrase inhibitors are recommended first line for everyone naive, actually also have more data on the safety of integrase inhibitors in pregnancy, and making sure we keep in mind what the mom might have previously been on, especially if they had past exposure to injectable cabotegravir. I remember because of the concern for Levi and all the other things, usually we would switch, and we just don't have enough data of cabotegravir in pregnancy. But I am going to show you a slide later on that updates that information. I updated this slide. Originally, it was regimens not recommended, and then I actually put in currently, because again, we're getting more and more data about pregnancy exposure and newer regimens, especially these long-acting regimens. And so many of our previous, especially protease inhibitor based regimens now are boosted with cobicistat. Not just rilpivirine. We've had decades of experience with rilpivirine. I mean, sorry, not rilpivirine. Ritonavir boosting, but we're getting more information on cobicistat as well. The guidelines were updated recently that really using this term of shared decision making. I think a lot of us first became aware of this when there was a concern of dolutegravir use, and dolutegravir may or may not have been associated with birth defect, and over time found that it was not an increased risk for birth defect. But so many of our colleagues and actually patient advocates in resource limited settings actually did not want to not have access to dolutegravir, even in pregnancy or just as being a woman or having childbearing potential, that we really started to be more mindful of making sure that we express and give information to our participants in studies and patients, and letting them know the risks, and really posing more of whether or not they are willing to take the risk and possible increased monitoring with some of the other newer regimens. So similar for cobicistat containing regimens, while we don't have enough information and there's some lower plasma drug levels, it really should be a shared decision with the provider and the patient whether or not to continue on a regimen, and if they should switch during pregnancy. Alternative regimens, my previous slideshow was kind of recommended as first line, but we're getting new information on not just safety, but new data on this one. I do want to point out for anyone who's using darunavir to prevent mother-to-child transmission during pregnancy, that in pregnancy, it's supposed to be a twice-a-day regimen. Oftentimes, we try to make things as easy as tolerable or once a day, and also sometimes with just increased hyperemesis. Ritonavir is not necessarily always well tolerated, but for anyone using boosted darunavir, boosted with ritonavir, be mindful that it's supposed to be dosed twice a day in pregnancy. And part of that is, during pregnancy, the amount of blood volume increases almost to 1.5 times normally. So lots of times drug concentrations are decreased because of that increased volume in pregnancy. In the spring, we had updated data on the use of bictegravir in pregnancy. So bictegravir is now on the alternative regimens, but bictegravir is one of the most commonly used regimens here in the States. So this is really the largest real-world cohort, a retrospective analysis, so not a prospective clinical trial, but really kind of gathering data on people who became pregnant while on big FTAF. So in terms of the rates of viral suppression, most of those women who had actually received or who got pregnant while already on big FTAF continued it during the pregnancy. They weren't switched to a preferred regimen. 85% of those started this regimen during the pregnancy, and some were actually switched off. And out of this study of 147 women who had actually had bictegravir use in pregnancy, there's only one case of mother-to-child transmission, and that mother, again, had acquired acute HIV during pregnancy. So that child, that newborn actually probably likely became infected early on during the pregnancy, where the viral loads were likely high. We've seen it in the millions to several millions. And while most HIV mother-to-child transmission happens to the time during delivery, you're more likely to transmit HIV to the fetus if you have acute HIV. And the other good news was no apparent adverse effects on pregnancy outcomes in terms of low birth weight, stillborns, and anything of the sort. And the perinatal guidelines are evolving. But the bictegravir levels actually still remain above the necessary concentration during pregnancy, so expected to still keep the mom undetectable. And earlier this year, the label, the package insert was updated to actually, if they have no risk factors or no resistance, actually can continue on Biktarvy during pregnancy. Finishing up with some pregnancy data. Also, earlier this year, we got more information on pregnancy outcomes with cabotegravir, and also some more data at the July meeting in Germany. So again, remember, this is the open label extension of HIV, cabotegravir for prevention in women in sub-Saharan Africa. And what they did see, the terms of poor pregnancy outcomes and low birth weight, we saw cabotegravir did not give higher rates than expected. The infant growth rates or curves were similar across all cabotegravir exposure groups, whether they were on cabotegravir while they got pregnant or previous cabotegravir. And there was a small percentage of those who were small for gestational age and in terms of the newborns, and that's actually lower than expected. The expected rate is about 10 to 30%, so average about 20% small for gestational age in that area of the world. So this actually was lower than expected. And neonatal death rates actually was about what's expected for that part of the world as well. The other thing that I thought that was interesting in this abstract is how to be mindful about whether or not these numbers for spontaneous abortions were actually correct or should be interpreted slightly differently, because they had to take into account that legal abortion is not necessarily legal in some of these parts of the world. So whether all of these spontaneous abortions might have been I wouldn't say uh, induced or self-induced, but not necessarily the same terms that we would use. Interestingly enough, so the data that was presented on the PURPOSE trial, the lenacapavir for prevention study, there were women who actually became pregnant. The lenacapavir study was also published in the New England Journal of Medicine the same day that the data was released in Germany. So if you read the study, you actually have to go to the appendix, the hidden in the weeds at the end of the study. And there actually is some data about women who became pregnant on the trial. The trial actually had you sign a new consent if you decided to continue on with the injectables or continue on in the study. So in terms of the number of confirmed pregnancies in those women who actually were randomized to receive lenacapavir, so just nearly 200. Remember I said 200 is that threshold where we get enough data to be able to change the guidelines or add it into the information run. And what we've seen is actually similar safety. So remember, we can't determine mother-to-child transmission because no woman in the lenacapavir arm actually acquired HIV, but you can look at numbers in terms of how many completed pregnancies and the number of births and abortions. So hopefully we'll get more information about birth weight or any birth defects over time. But this is exciting that we are going to have data not just on pregnancy with cabotegravir, but also shortly with pregnancy outcomes with lenacapavir, the sub-Q capsid inhibitor that's given once every 6 months. Lastly, I just wanted to spend some time to go over information about comorbidities and complications. While it's getting easier and easier to treat HIV and keep people undetectable and keep them alive, preventing OIs, and actually even preventing them from having HIV in the first place, we still do have concerns about how to prolong the quality of life and prevent diseases that actually decrease their life expectancy. So I just wanted to review briefly the REPRIEVE trial. REPRIEVE and all of its updates were all the rage 2023, but we do get some updates from it at the recent conferences. So REPRIEVE was the big study really seeing, is there any intervention that we can do to prevent death and morbidity from cardiovascular disease, which is actually a major killer for people living with HIV in this day and age, right? 30 years ago, it was more about people dying from PCP and cryptococcal disease and other opportunistic infections. Now that we have good HIV treatment and we can get people undetectable and even have their life expectancy approach that of someone without HIV if they're in care and on medicines, cardiovascular disease disproportionately affects HIVers and at an earlier age. And compared to people without HIV, the regular calculators that we use, things that include their cholesterol and family history and blood pressure, even if we do those traditional risk assessments, it still underestimates risk of heart attacks and strokes in people with HIV. So those calculators aren't necessarily a good predictor of who might need to be on a cholesterol lowering drug, even if their cholesterol is normal. So the Reprieve study actually really said, is there something that I can do to decrease some of this inflammation or problems? And there's already data that one of the cholesterol medicines, the class, the statins, actually can decrease inflammation, which we think is a big player in people without HIV. So can we maybe modify some of that extra inflammatory response or things that we're doing for people living with HIV who wouldn't necessarily meet criteria to be on a cholesterol lowering drug, and to see if that would make a difference. And they didn't just want to look at blood tests and markers and inflammatory markers that we can't pronounce or we don't routinely measure in clinic, but did a much longer study to actually see if we can actually see the number of heart attacks and strokes and people who needed an intervention to clear out their peripheral artery disease and all this other stuff living with HIV. So randomized to either get pitavastatin, the cholesterol lowering drug, or to get a placebo, and was planned to go on for over 7 years to see if we can make a difference. And last year, 2023, they actually had to stop the Reprieve study early as well, because what they saw was a statistically significant difference in the number of what's called major adverse cardiovascular events, or MACE. So think of those as your heart attacks and strokes and things like that. Much fewer rates of that for people who were randomized to receive this pitavastatin. So again, remember, this study was conducted in people 40 to 75 years old with HIV. They actually did not meet criteria. They had good cholesterol levels. They hadn't had a previous heart attack. In the real world, they wouldn't have actually met criteria to be put on a statin, but the study was stopped earlier than expected, because there were so many more of those bad outcomes in the people who did not get a statin. They found a 35% reduction in major cardiovascular events in those who were randomized to receive pitavastatin, and only some essential muscle pains or muscle weakness early on in terms of side effects, but usually not serious enough for the participants to stop. So this actually changed the standard of care, because by the end of last year, earlier this year, the guidelines were actually changed to say that actually for people living with HIV, even if they didn't meet criteria, the old criteria to be on a statin, this data was so compelling that it's now recommended for people to be on a moderate intensity statin if they meet those criteria. And remember, I told you that there was a risk score that we usually use to decide who needs to be on a statin. And even though everybody in the study was with a low risk factor, it was beneficial no matter how low your score was. And I like to put this on the slide, this part here on the right. It's what's called number needed to treat. Kind of, is it really worthwhile? Am I going to prevent one heart attack, but I have to give these statins to tens and thousands of people? Does that really cost effective, or is it really helpful? But overall, the gist of this on the right is saying that the number needed to treat to prevent a bad outcome, a heart attack, stroke, is actually on a really reasonable low scale, comparable to that of what we do for even blood pressure medicines, right? We routinely give people blood pressure medicines to prevent cardiovascular disease and bad outcomes, heart attacks and strokes, with a similar number needed to treat. Because that's a reasonable question in terms of not just global health or resources, but all medicines have possible side effects. But this number needed to treat is low enough that it actually changed the guidelines. So we wanted to see there's more information about what really was this pitavastatin doing, because it's a cholesterol lowering drug, but these people didn't have high cholesterol levels. So there was already some data that statins don't just help lower the lipids, but can actually kind of remodel or decrease the size of plaques in the coronary artery or atherosclerosis. So if you look at here on uh, B, B are people who are randomized to not get a statin, and people in the A group were randomized to get statins in some of these older studies, non-HIVers, and you can see the sizes of the plaques actually getting smaller in the people who got old statins. So Reprieve also did a study to actually look at a subset of the patients, about 800 patients who were getting the pitavastatin versus placebo. We're actually going to do CT scans to look at their coronary plaque. We're going to look at the hardening or the amount of hard plaque that they have in the coronary arteries, and actually measure them over time, over 2 years, to see if there are any changes, and compare that with the people who got placebo versus pitavastatin. What they've found is that there was a change in the plaque or soft plaque, non-calcified plaque, in those who did get pitavastatin. And it didn't matter if they were male or female, what part of the world they were from, what CD4 count. There was decreased plaque with this pitavastatin, right? And what they also found was that the change in plaque and also some of these inflammatory markers was more than predicted than just by the effect of the pitavastatin on their LDL cholesterol, their bad cholesterol. So the decrease or the improvement in their bad cholesterol alone did not explain all the benefits that they were getting. Earlier this year too, they actually looked at a whole bunch of markers, not just cholesterol and CRP or other inflammatory markers. They looked at, I think, over about 200, markers, scientific in the lab markers, to try to find, is there one specifically that we can explain what's working or what the target is or what's making the most difference? And I thought this was interesting. They actually found that pitavastatin reduced these non-calcified plaques because of one of these collagen forming enzyme or proteins called P-colci. I never heard of it before. I had to listen to this, the presentation to figure out how it was even pronounced. But essentially, P-colci seems to be one of the big stars of what's driving all of this reduction in plaque. And I put a little cartoon here that I found in one of the papers, is that pitavastatin actually decreases the expression of this pro-collagen forming protein, and about 84% of the decrease in that soft non-calcified plaque can be mediated, or this change was mediated by this particular collagen precursor, P-colci. So interesting, more to come, but whether this might be a target in the future, we will see. Another interesting presentation or a poster that used data from Reprieve was actually looking at a particular antiretroviral that we use called abacavir, and looking to see if there's any signal with abacavir and who's more likely to have these heart attacks or strokes. So essentially, abacavir is not used as often as maybe some of the other antiretrovirals, but it is a component of the tablet that includes abacavir, dolutegravir, and lamivudine. The brand name is Triumec. But the analysis actually wanted to take a look to see if the use of this particular drug was associated with any of these bad outcomes. So they had of all the people who had ever used abacavir or still on it, had a median of about 5 years of follow-up. of all of these people who had exposure, of all the people in the study, about 1 in 5 had previously or currently used abacavir. So that's about 1,700 people. About 9% of those had actually used it in the years past for about at least 3 years or so. And about 13% of that 22% were actually currently using it when they were randomized to start the study. And what they saw was, for those who had prior abacavir exposure, increased risk, and those with even compared to those with no abacavir exposure. And in terms of adjusted and unadjusted events, they found that people current and former use of abacavir in your HIV regimen was associated to an approximate 45–50% higher risk of eventually having a heart attack, stroke, or what we call MACE, major cardiovascular event. And it was not changed. The abacavir use or history didn't make a difference what other HIV classes were used with the abacavir. And also other HIV medications, the tenofovir, protease inhibitors, or even the thymidine analogs, we think of AZT or some of the older ones, none of those were associated with subsequent MACE or poor adverse events. So only the abacavir seemed to have the biggest signal. This was actually surprising to me. And, the question was, were more of these people put on abacavir because of some other risk factor or another reason that they thought they might have been more prone or had a higher risk of developing that? But remember, to be included in this study, all of that stuff was taken into account. So you couldn't actually have diabetes, or you couldn't actually had a previous heart attack or risk for a cardiovascular event, or you wouldn't have met criteria to be included in the study. So this was actually a little bit surprising. It's actually interesting, even though this just came out this summer, some of the guidelines, I think the European guidelines have actually kind of moved a abacavir down to a abacavir containing regimen to a least favored or alternative regimen. So it'd be interesting to see whether the US guidelines might follow suit and kind of demote abacavir based on some of this data. Just finishing up the last few slides, I wanted to talk about kind of what's on the horizon for people who are highly resistant or have very resistant virus and maybe fewer options to get undetectable. I call it the DEF study really looked at, in terms of what our big guns are. I think of dolutegravir as our integrase inhibitor. That's our biggest gun or our gold standard, and similar boosted darunavir. This study actually compared people who are failing their first regimen and kind of randomized into either groups, dolutegravir base group, a boosted darunavir base group, or the combination of the two, and really see what might work better. And essentially, what the data showed is that the regimens that contained dolutegravir seem to have actually improved outcomes and better virologic suppression over time, even after 1 year, compared to the other combinations. The last few slides, I just wanted to speak about interesting kind of what people are doing in real life. Again, from UCSF and some of our colleagues at UCSF and around the country, they had actually come into contact with patients who don't have a lot in terms of options for getting them undetectable, and may even have some resistance to rilpivirine. Rilpivirine's been around almost 20 years, but how about putting two of the injectables together? So this was interesting. This was actually some data on combining the long-acting cabotegravir. So remember, that's the integrase inhibitor that can be given once every 2 months, plus long-acting lenacapavir sub-Q once every 6 months, not FDA approved to be used together, But let's see what people have been doing in the real world. So these are people, again, with challenges to oral antiretrovirals, and oftentimes actually may have had resistance to rilpivirine. So CAB plus rilpivirine was not an option. So providers were putting together these uh, long-acting injectables that have two different mechanisms of action. So small data set, only 34 patients. 3/4 were assigned male at birth. Just under half were Black, and about a third identify as Latino. Again, in terms of what their challenges to complying with oral antiretrovirals in the past, homelessness or housing insecurity, and a lot of active substance use. Only half of them were already suppressed, so a little bit more than half actually had detectable viral loads at the beginning. And we're either receiving lenacapavir plus either cabotegravir once monthly or every 2 months. Some of them were using rilpivirine, but some of them actually were not. You know, cabotegravir for treatment comes together with rilpivirine, and some of the providers say they were either not giving them if they actually already had documented resistance to rilpivirine. The most common reasons for the addition of the lenacapavir was, of course, that 60% were resistant to rilpivirine already. Some of them had integrase inhibitor mutations, and some of them actually had some viremia. Interestingly enough, 94%, 32 out of the 34 people actually became undetectable after the addition of lenacapavir to this regimen. Last couple of slides is talking about people thinking outside of the box. For, again, people who are highly treatment experienced, looking at oral bictegravir alone, so not in the combination of Bic-F-TAF, but for this study, bictegravir as a standalone tablet plus oral lenacapavir as a tablet, randomized, in a small phase 2 study to see people who are on really complex regimens, protease inhibitors plus integrase inhibitors plus NRTIs. You can see a wheel of a pie graph of all of the different distributions of these complex multi-tablet regimens that they were on. And really the most common reason for being on these regimens was just the extent of their resistance, and most of them resistant to all of the options for single tablet regimens. And essentially this just really blew my mind with really just how well everyone looked at the end of 6 months. So the combination of oral Bic and oral lenacapavir, highly effective in achieving and maintaining viral suppressions in people who had switched from many multi-tablet regimens, even with some assessment. This was a phase 2 study, so they actually found the right dose of bictegravir and the right dose of lenacapavir that they plan to use, and really supported continuing looking at this combination. And lastly, I wanted to say, actually, the reason why this combination is probably still being looked at is, as you can see here at the bottom of this slide. But in terms of long-acting agents, what's currently approved, we have for treatment the combination of injectable cabotegravir plus rilpivirine, lenacapavir with an optimized background regimen of tablets as of right now. Has been FDA approved for those with highly treatment resistant virus. And we didn't mention it in the talk, but this monoclonal antibody that can be given, an attachment inhibitor antibody that can actually be given once every 2 weeks. So not commonly used. We don't have that many folks in clinic who use it, but currently that's what's available. In terms of prevention, cabotegravir, in terms of long-acting, is already approved. The dilpivirine ring, intravaginally monthly ring, is actually available. And I just told you about the updates on the data for lenacapavir sub-Q once every 2 months. Now that there's 2 studies that have shown efficacy, not just efficacy, but also superiority to oral PrEP, the company will now actually be going to the FDA for approval. And in terms of what's in the future, there's some tablet regimens. Islatravir, which hasn't been, had some bumps in the road for approval. They actually are looking at some oral, maybe once weekly regimens that can be combined with an oral once weekly lenacapavir. Doravirine is actually, sub-Q is actually being looked at, but I put it here in red is based on the data from the last study. Remember that last study that combined bictegravir with lenacapavir? It turns out that there's data here on the right looking at a subcutaneous formulation of bictegravir that can be dosed once every 6 months, similar to lenacapavir that's already dosed sub-Q once every 6 months. So I anticipate that they probably be looking at, when there's more data, possibly combining this long-acting version of bictegravir with long-acting lenacapavir for a possible new combination for long-term treatment that can be dosed once every 6 months. All right, so wrapping up, I think I've gone a little bit over with time, but in terms of the key points, long-acting injectables not only are here to stay, the wave of the future, but looks like there's more on the horizons. And now that there's more clinical experience, actually even looking at it for people who maybe have not met original criteria to be included on the original studies. So people who are may not be undetectable or have either mental health or homelessness or active drug use, maybe still being able to benefit from this as well. There are some early clinical trials that looking at even a dose of cabotegravir formulation that can last even longer on the 4-month instead of 2-month range, but that's not quite ready for prime time. I did not include that in our data set, but more news on the horizon. Lenacapavir, the new in class capsid inhibitor, dosed once every 6 months, now approved for those with resistant virus and highly treatment experienced, but now new data on its superiority for PrEP when compared to oral options. Will likely go to the FDA and hopefully be approved probably by next year. Spoke briefly about HIV prevention and pregnancy, new data even for those who are HIV uninfected of the safety of cabotegravir and lenacapavir, the long-acting injectables for those who became pregnant even in some of the PrEP studies. And lastly, new combinations are on the horizon, not just favorable data for CAB plus LEN, but interesting to see as new formulations of long-acting and maybe even, as I mentioned in this previous slide, lenacapavir, but also sub-Q bictegravir in the years ahead. So I want to thank everyone for their time and now open to questions. Thank you so much, everyone.
Thank you so much.